So I've been given a dubious task after lunch to talk to you about science and definitions and a little bit of medicine, and then hopefully sprinkle in some good, usable stuff, what happens with doctors and what doctors deal with and how they deal with their patients when it comes to addiction and handling addiction. Okay, so this is where it all started. Years ago, it comes from the Greek opium or juice. And there you can see it. You scratch the opium, and there out comes some of the latex that they'll dry and utilize for pain control. So back in Greece, they were using it for pain control. When I was growing up, Juice was a football player. And now Juice is what A-Rod is trying to dodge the remainder of the Major League Baseball with. So this is the root of the problem here. A little deeper, I think, pain and the treatment of pain is really what we're looking at, and you can see it's a big definition. There's a lot of stuff that go into it, okay? If you look there, if it was simply an unpleasant feeling conveyed to the brain by sensory neurons, that's kind of simple. Let's just stop it, and then we don't have pain anymore. I think what you all realize, because you deal with these clients, just like I deal with these patients, is there's a whole bunch more that goes into it. It's their awareness, it's their perception, it's how they interpret that painful stimulus that is important and valuable here, and what makes the treatment so difficult. So some more definitions, and I'll zoom through this as quickly as I can so we can talk, and you've heard some of this stuff already and from me over the past several years. Acute pain is pain that's less than 90 days of duration, all right? Chronic pain, greater than 90 days of duration. And then certainly from studies, we know that if somebody's being treated with opiates for more than 90 days, that's where troubles begin. Whether it mean lifelong use of opiates, whether it mean they trundle down another pathway of abuse or addiction, but we know that's kind of what we in medicine at least are using as our cutoffs there. We're going to deal with transduction, transmission, modulation, and perception. We're not going to talk about interpretation or behavior. You've seen this, I think, 2 or 3 years ago in San Diego, and I'm not going to make you docs, but basically the big four is transduction. So we get that impulse, whether we hit our thumb with a hammer, and it hits those alpha, beta, alpha, delta, and C fibers, and then they run it right up the chain you can see there, and they transmit it via the dorsal root ganglion, or the dorsal horn at the spine. And up the spine it goes to the brain and higher levels and things. So why is the dorsal horn important to you guys? Because when you send them to the anesthesiologist and stuff and they're doing injections, they're going right to that dorsal horn there. I guess I could point with a pointer instead of my finger. Right there, and that's also where the rhizotomies are being done and the treatments are being done for the nerve blocks and that kind of thing. So this is just a little of the anatomy. You probably know some of this stuff, but it's kind of good to take a look at it and see why are the docs approaching this area, what are they doing here. The other part about this is there's a lot of receptors in here in the dorsal root. There's a lot of theory when it comes to the modulation of this impulse. So why I hit my finger with a hammer, I get a certain painful impulse, and Eddie hits his finger with a hammer and he gets a different impulse, or a different perception of that pain. And it has to do with some of these theories. These are old theories. The gate theory is still something that's being proposed out there as a way to transmit that pain or modulate that pain before it gets transmitted up to the brain. And then the big question, can we open or close that gate pharmacologically? You know, we know we can do it with needles, and we can do some things with needles to decrease that modulation of pain. What can we do pharmacologically there? As I stated before, there's a lot of opiate receptors in there, okay? And you can see them here, and there'll be a test later about mu, kappa, and delta, so listen hard. That was a joke. Then there's a bunch of it up in the brain as well. So there you go. There's just an outline in the brain of where you see a lot of the opiate receptors. And that's why these folks that we have on these pain medications, the opiates and stuff, there's so much involved, whether it be psychologically, whether it be physically, and what have you, to cause the addiction and or some of the side effects that we see from these medications. So just briefly, opiates can change the limbic system, which controls emotions, to increase feelings of pleasure. Okay, so maybe that's why we've got some of these folks that are getting addicted to this kind of thing. They change the brainstem, and the brainstem is a very important area for most of us because most of us don't have to think about breathing and things of that nature or having our heartbeat. That's the spot in the midbrain there, or in the brainstem, where all of those impulses are taken care of. And you can see right there, it's littered with opiate receptors. Opiates can block pain messages being transmitted by the spinal cord up from the body to the brain. And that's one of the reasons we're using opiates, obviously, to treat these patients. And then perception, okay? It's the resultant interaction of transduction, transmission, modulation, the psychology that comes into pain, and then individual characteristics, okay? And I think some of this is where the patient is or where he's about or what he's about when he is involved in the painful activity, whether he sprains his ankle at work, whether he's an NFL football player or one of our military guys. You know, they talk about NFL football players, and those collisions are the same as a car accident, and they do it 20, 30, 40 times a game. And yet they're not out the next game saying, well, I can't do it because I've got a work-related injury. So obviously our perception and what we think about the incident that's going on is important here. And so, as you can see, it's a multi-layered kind of a deal here when we start treating pain and we start talking about opiate abuse and how to treat and how not to treat. So, real quickly about some pharmacology. Analgesic effect is to decrease the pain perception and decrease the reaction to pain and increase the pain tolerance. That goes anywhere from the dorsal horn all the way up to the brainstem and different areas of the brain as well. Attaching to these receptors and things, and we're going to zoom through that because that's not as important. This is an important slide, I believe. It talks about the neuroadaptation. So when we talk about tolerance, it's a neuroadaptation resulting in reducing drug effect with the same effect of the med. So here's one thing when you're talking to the doc or you're talking to the patient and you say, well, this patient has a tolerance now to the medication. Dependence. So the more you use opiates, the more you're going to depend on them. Okay? Addiction usually has something to do with the euphoric feeling, so up there in the limbic system, and do I get that feeling from the medication? Because if I do, I want to get it again because it feels good. So if it feels good, do it, right? So, and then withdrawal is what happens when we abruptly discontinue the use of opiate meds because all of these opiate receptors are used to being bathed in opiates and now we don't have it. Here are some symptoms of withdrawal: agitation, anxiety, increased tearing, insomnia, sweating. Sounds like a Pittsburgh Steelers fan these days, right? So, cramping, diarrhea, dilated pupils. This is important for you all because if you see somebody in your office and you see some of this stuff going on, it maybe at least it makes you think about it a little bit and think, well, has this guy stopped using his meds? Did he run out a week ago and not tell his doctor what's going on? So not that you're going to treat it, but if you see some of this stuff, I think it's important to know a little bit about this. Okay? There's different ways to get these patients off of the opiates if that's the route that we need to go to. Okay? You can see that in 1 year, only less than 25% of the people who quit cold turkey stay quit cold turkey. So not real good statistics there. There's some medication-assisted ways to do things, whether it be methadone, naltrexone, and buprenorphine. I was asked to talk a little bit about Subutex and Suboxone. These are newer medicines out there for treating the addicted patient. The folks or the doctors who prescribe this actually have to utilize a certain regulatory, that's a REM system basically is what it's called, and so not every physician is able to do this. You have to go through different levels of not necessarily licensing, but registration and things so that you can use Suboxone. All right, and I know in Phoenix there's a handful of guys that I would send my patients to if we felt that that was the way that we had to go with any of this stuff. The FDA has a surveillance program with this, okay? Only qualified doctors can prescribe this medication.
Can I jump in for a second?
Sure.
On Suboxone, one of the really neat things is docs who are certified to prescribe the medication, the first year that they're approved to treat, I think they're only allowed to carry a caseload of 25 patients or so, and once they're at full approval, maximum 100 patients on that medication, so that they have to give a total care, not just writing scripts, have to see them for counseling, supportive assistance, to help cut into that 98% rate of recidivism.
So No, we're actually getting right to that. So the way it works is it's a partial opiate agonist, okay? Some patients do feel, so it's an opiate, so we're replacing the opiates they were abusing with another opiate. Some patients do feel a little bit of the euphoria with it, but most of the patients, when you talk to them, they feel normal. So instead of withdrawing the opiate from them and having them nauseated, constipated, jittery, shaken, and stuff like that, we've got a patient who can actually function more normally. The medication, it's got some really interesting things to it. It's very long-acting, so it sticks in the brain for 24 hours, okay? So that's a pretty cool thing about it. It's also got a ceiling effect. I could give you bunches and bunches of it, but you're not going to get higher and higher if I give you bunches of it, okay? Unlike many of the other opiates, well, if you use a little bit, I give a little more, maybe I get a little more high, or maybe I get a more pleasurable feeling from that, okay? So it does have the ceiling effect, which leads to a single dose, which is kind of nice for the guys prescribing it, that's usable there. Suboxone also has naloxone in it, and naloxone is actually it's an opiate, it's a blocker, okay? And that's a little extra thrown into the medication because we were worried that patients might start abusing the Suboxone now because maybe they'll grind it up and snort it and maybe they can get a quicker high from it because it gets in their system quicker, or maybe they'll grind it up and then they'll inject it, so they'll melt it down and inject it. Naloxone is interesting because it's going to go up into the brain, it's going to attach to all those receptors, and the patient is basically going to cold turkey themselves if they utilize this medication incorrectly. So part of the REM system is what it's involved with is actually teaching patients, as well as the physicians teaching the patients, the system or the patients get significant education about using this medication appropriately and not inappropriately using this medication where they can actually develop withdrawal symptoms.
Off the market if it's not already on the market, and switch to a sublingual film, which means it's a little film you put under your tongue, you dissolve it. This way people can't crush it, mix it with water, and do a nasal lavage to get high. So if you have any patients going on it, you want to make sure they're on the sublingual film, not the tablet, not the injectable. The reason you want to avoid the injectable is the injectable lasts for 30 days. People who are substance abusers fall off the cart along the way, so you don't want them having this in their system necessarily for 30 days at a clip.
You can use it for pain as well, yes. Well, the point of it is to get the people off of the ascending doses of opiates. It certainly can be because it's a longer-acting pain medication that they can't abuse. So absolutely. I don't have any experience with it, to be honest with you, treating with it.
If I could, and I'm not a physician, but I was on the Suboxone task force when they were looking at workers' comp, and we actually did interviews with actual patients, and they say it did help control the pain. It also stopped their physiologically, and I know the doc's going to get into this, stops the craving for the drug, but it is a way of controlling the pain and allow them to lead a positive life. The patients swore by it, as did their families. It's also used, believe it or not, heavily in the prison population.
Yes.